Welcome to Going In Blind. I'm your host, Zach Tidwell, and my guest today is an osteopathic doctor who's been working in both primary care and addiction medicine for the past 6 years. Please welcome Dr. Sarah Nassir. And to everyone at home, thank you for listening. Please take a second to help me grow the show so that I can keep delivering these conversations week after week for years to come. Subscribe, rate, and review the show in whatever podcasting app you're using right now, and check out the show notes to follow me on social media and YouTube as well. When you share your favorite episodes, tag me and use the hashtag GoingInBlind. You can also join my mailing list at zachtidwell.net. And if you know someone you think I should talk to, have them send me an email at contact.goinginblind@gmail.com. Dr. Nassir, thank you for coming. I think you are our first doctor on here, so you're making waves.
Wow, Zach, thank you for having me on the show. I didn't realize that. I feel so special and privileged to be on this show as the first doctor. So thank you for having me.
Yeah, I'm very excited to get into all this. This is something very near and dear to my heart. Yeah, I can't remember if I filled you in on this or not, but I struggled with alcoholism. I'm about 17 months sober now. I tried all sorts of stuff. I tried AA, I tried outpatient rehab, I tried inpatient rehab, and at the end of the day, my own, I hadn't developed the coping skills to deal with things in a healthy way, even after all of those different attempts and just me trying to even get sober on my own. So I kept falling back into drinking and eventually was able to just get out of that and finding an approach that worked for me. But so can you to follow along with that and set a little context for people listening, can you give a little background as to your credentials and what you're doing today before we get into this?
Of course. And before I do that, first of all, Zach, congratulations on the success that you have achieved with your sobriety. It is not easy, what you have accomplished. So I hope that you're very proud of where you are today and the work that you put into becoming the man that you are. And a little bit about me, I am Dr. Sarah Nassir. I am a board certified osteopathic family medicine physician who went and became subspecialized in addiction medicine. And so I bring that to my patients when I'm talking with them to approach them from that osteopathic principle of the body being a unit of mind, body, and spirit, and the the concept, the tenet that the body has the ability to heal itself. So our jobs as doctor is to help the body get the things it needs to um, you know, basically take care of itself, and for us stupid doctors to basically get out of the way after that. Um, and so that's what I try to be present with my patients who I take care of in the methadone clinic. I'm mainly now in that setting where I'm dealing with opioid use disorder. And so I'm prescribing medicines purely at this point for methadone and buprenorphine, or also known as Suboxone. Um, but before this, for over 6 years now, I've been taking care of not just the overall primary care health of a person, but also the other types of addictions, substance use disorders is what we like to call it, for alcohol, methamphetamine, cocaine, benzodiazepines, on top of opioids. So that's my credentials as a doctor.
As one would expect from a doctor, there's a lot to unpack there, and I'm curious. I'm always curious. I think with niche things like this in very narrow scopes, when people have chosen to go into a very direct and very concentrated area like this. I mean, why? What led you to go into addiction medicine? Did you grow up in a household with an addict? What was that?
Great question. I do get asked that question frequently, and the straight answer is, or the one question that's on top of everybody's mind is, what's your personal experience with addiction? Mine is basically that my dad used to smoke tobacco. Everybody around me smoked tobacco. So that's like the bare minimum amount that I've been exposed to. I have some relatives who, from the sounds of it, have suffered from alcohol and maybe heroin and cocaine addiction. This happened at a time when, I didn't understand the world as much. So I was very young and I wasn't informed too much about it. But how I got into this niche is, I think, when I was in medical school out in West Virginia, I think the first thing that comes to mind is I was doing my OB rotation. And so that's where you learn how to deliver babies or see doctors deliver babies, because when you're a medical student, you don't get as much hands on experience. So I was just hanging out in the NICU, or the neonatal area one night after we had delivered a baby, and there was this baby there having a really hard time with what's known as neonatal abstinence syndrome. This is where a baby that was exposed to drugs like opioid inside the uterus, or like in utero is the word we use, which means while they're inside the womb. Um, they kind of get, the involuntary, opioid dependence,
It's a
because
secondhand addiction through mom.
exactly,
Yeah.
exactly, thank you, that's a very good way of putting it. And so now that they're outside of mom who's not using, now the baby's having the withdrawal symptoms, and that was my very first encounter with the disease of addiction and its impact in a medical way,
Does
and
does that cause, because I know like fetal alcohol syndrome causes developmental issues. Does being exposed to opiates like that as well?
it it doesn't develop into the severity of malformations, congenital malformations that we see with alcohol abuse. Like, you will have the faces or the facial features, like a small head, a small jaw. Mental retardation is very common with the, fetal alcohol syndrome. But with the opioid addiction, I have to look into if it increases the likelihood of opioid dependence down the line, but it doesn't cause, or it's not known to cause, those obvious congenital malformations or deformities.
That would
Does
be interesting if it does set them up to be more likely to develop the dependency later because they've already had it. I mean, that's like, if an alcoholic goes back to alcohol
yeah.
after being sober for 20 years, like they're still going to have that addiction.
Yeah.
That's interesting.
However, there is this, whether, I mean, it's called epigenetics. The exposure to certain ex- um, triggers can impact your genetic expression. So your DNA, the genes in it, get expressed differently based on your outside situation. So the question becomes, is this going to be like, future likelihood of increased addiction? Is that going to be an epigenetic problem, or is it going to be a hereditary genetic problem? Because hereditarily, research studies have shown that if you have parents or, you know, relatives, blood relatives, if you have there is genes for addiction. So if you have a family member who has addiction history, there's a high chance that you can genetically inherit it. So now I'm getting more into the scientific aspect, right? Epigenetics is basically environment causing you to be more likely to have that thing, versus hereditary genetics is like it's like getting blue eyes or black hair from your parents. So if you have those certain genes, then you are 40 to 60% more likely to have the chance of becoming addicted to the substance than somebody who does not have those genes. So twin studies basically showed that, you know, a twin without those genes, even though they were raised in a household where there were drugs and they did it, they would move on from it. They wouldn't be like, oh, I can't let go. Versus a twin who was adopted into a non-substance use exposure household, they, get their first drink in college or something. and then they become hooked on it, like the same amount of exposure as somebody who doesn't have the
Really?
genes. So the genes do have a strong predisposition for
Well, and that's
facilitating.
yeah, I'm glad you touched on that because as soon as you said 40 to 60%, my question was going to be, okay, how how confident are we in those numbers? Because there are still then the environmental factors growing up. That is so interesting that still, even after having been removed from that situation, that develops. I
Yeah.
guess I've never actually heard that before, but
It's interesting, isn't it? It's something I encountered when I had to study for my certification, and it looks like a very well researched data.
yeah. I mean, I think that's so interesting. West Virginia, I would imagine this outside of that one experience. You're also, I mean, you're in Appalachia, which got hit the hardest and is like when you think of
Hmm.
the opioid epidemic in America, you think of Appalachia and in the hill country and in these communities. Is so was it that singular experience that led, or what's the
No,
trajectory after
no,
that?
that was the first exposure in some ways. Give me 1 second. Sorry, my throat is doing that thing like where it doesn't want me
Yeah.
to talk, so my voice is
Was
changing.
was that a common experience out there?
um, I think I probably had blinders on. I didn't recognize it versus now having experience, like, so much experience. I can recognize more. S- So it's more like I think I just didn't know the signs and symptoms as much. But the reason that experience really stands out to me is that I was of the people who held a lot of prejudice, and bias against people who were using, where it's like, oh, it's a moral or ethical problem that they're using, that they can just quit whenever they want. Because the nurses who were taking care of the baby, we were basically having you know, a a stigma fest on the mom. Like, how could the mom be so bad that she would do this to herself and now the baby is suffering? So it wasn't just me that was doing this, a medical student, third year medical student.
Okay, I'll pause this real quick so you can
Hmm.
go do one that.
Yeah. So, yeah, so the West Virginia situation was my first exposure. And then I feel like I got more into it when when I was in New York with my residency. So it's funny that you say that the Appalachian was one of the hardest hit with the opioid epidemic. However, now looking back at it, I feel like I was meant to be doing this because life took me to the place that was also on the drug route that went with they got the fentanyl in Mexico and then it went up to Canada. And so the upstate New York City where I was doing my residency, the doctors and the policymakers that were trying to raise awareness about the opioid epidemic, one of the things that they mentioned was we're sitting on the highway, the opioid highway. And so there I was more aware. I became more aware because I was more involved in the treatment of patients who were suffering from opioid addiction, as well as, the prescription opioid problem. So
Well,
apparently, we were near a pill mill. One of the
what
doctors was pill mill in our area.
what year was this around?
This was like 2016, 17.
Okay. And I was curious because you mentioned fentanyl and I was like, okay, so this is still pretty recent. And I know said you've been in medicine for, I think you said six
6
years.
plus years,
Yeah.
yeah.
So,
Yeah,
okay. Very,
fentanyl at that time in residency, fentanyl wasn't as big, but it was part of the things that were going up with heroin and stuff. When I was there, it was more of that pill mill, like prescriptions, being overwritten, and then, suddenly being cut off, and then patients landing on heroin. Once I finished residency, a few months after that, the fentanyl started to become big, and now the fentanyl is just everywhere.
how much of to come back to the comment on those
Yeah.
prescriptions being overwritten, we hear I think it's common knowledge by this point that there was some shady stuff going on with Purdue Pharma and the entire medical industry surrounding opioids and specifically OxyContin. But with these prescriptions being overwritten, do you have any insight or did you have any experiences or can you speak to was this a result of doctors getting kickbacks for these prescriptions?
Um, not well, I wouldn't say kickbacks. One of the things that is discussed when we're talking about the history of, the role of prescriptive medicine feeding the opioid epidemic. It's more that pain was a metric. When you go to the doctor and they're looking for your satisfaction score, as well as to see if you got the care that you deserve. Like when they're taking a vital, like what's your blood pressure, what's your pulse rate, what's your oxygen saturation. One of the metrics that was the pain scale. Is your pain controlled? If not, here's more. And so there was that systematic support for this as well. And other things we are learning is that when we were introduced to, the opioids, initially it was like, it's a great pain medicine, it's a great painkiller, and there's no significant side effects, etc. So
Which
write
is
as
so
much as you
sinister
can.
because they knew that wasn't true.
Um, I
Not
wasn't
the
there.
doctors. No,
I
I
wasn't
mean,
there, so I can't speak to it. I haven't really been to any I think I entered medicine long after, what do you call it, the opioid pharmaceuticals were going to the prescribers. So I don't have any I don't have any experience to cite this from. But what I'm saying is more like second or maybe third hand knowledge because I learned it from like when the DEA trainings were happening and stuff. Um, they were saying like, so the doctors were getting this sense of security that it's okay to write these prescriptions and then you have these support, the hospitals and the they're saying like address pain because that means the patients will give us better satisfaction scores versus those whose pain is not addressed. They're not going to be happy and leave you bad reviews, so which is bad for business as well.
so yeah, it's like a meta thing almost where we just the system it doesn't drill into the nuances of that enough to where that was getting captured at the time. And then on top of that, then there's people who are starting to develop addictions, and we've heard of people shopping around to different doctors, and there wasn't any system in place to check if an individual was seeing three different doctors and receiving that prescription. And I mean, there still
Correct.
may not be because privatized medicine, I would imagine that's hard to integrate all those systems together. But as I as you continued along, why did you land on a methadone clinic?
Yeah, I'll be happy to go into that, but before I do that, let me um, elaborate a little bit on one of the things that, you know, it's not that private, like now we do have a lot more interventions in place to try and, prevent this from happening. So right now so the pendulum has kind of swung the other way
Okay.
where before it was like hyper free, and then there was this phase of like hyper scrutiny and hyper security. So those do exist. The result of that is that now we have state prescription monitoring programs. So if you get prescribed controlled substances, which are basically they have addictive potential, we are every state has this prescription drug monitoring program where we run whenever we're giving a prescription that's controlled, we're now like the standard of care is becoming that you check that to make sure that there's no doctor shopping happening. So
That is awesome.
yeah, so in some ways that protects us, but it's mainly like only the state you're in and whatever that program is looking into other ones. So I'm in California. The California allows us to check a few other local nearby states. Um, when I was in DC, that was also something it allowed to check, like, Maryland, Virginia. So, just, nearby, but you don't get, like, all across the country, you know? Um,
Yeah.
so there's that limit, and then other steps that are in place is, like, when you go to an ER, that used to be a huge center where people would be like, "I'm out of medicine, so now I'm in pain, so give me the prescription." So now some of the standards of practices are that the ER doc will only give you a small amount of prescription, no more than that. After that, you have to follow up with a specialist or your primary care doctor for continued monitoring and prescription. And then in primary care, when I did have patients who had legitimate reason for this medicine, because medicine at the end of the day, they have come around because we needed something to balance that that chemical balance inside of us. And that's exactly how I approach the medicine, and that's how I describe it to my patient, is that we're using these pharmaceutical interventions to help the body regain its balance, because once the body is back in balance or homeostasis, it does its job. We don't need to tell the body what to do at that point. So my goal with the way that I treat my patients with anything, not just opioid addiction, but be it diabetes, be it high blood pressure, be it thyroid disease, it's all about getting the body back towards that healthy baseline, healthy balance. Um, and so where was I going with that?
You're so yeah, with I want to follow on that. So, because I'm curious, and I think even almost in a similar vein to you mentioned, like you held until being exposed to treating people with addictions, like you held a certain idea in your mind of what that was and in a judgment. And I think even I've been aware of these drugs that can help treat addictions. I tried naltrexone and Antabuse while I was trying to get sober. Neither one of them worked for me because I would just find loopholes around either taking them or like drink right through the naltrexone to where I would still be able to black out, even though I didn't get to feel any of the fun part of the being drunk. But I think specifically in knowing of these drugs that are used to treat opioid addictions, I've had this preconception, maybe misconception in my mind of this is okay, you're giving an opioid addict more opioids to treat it. And so I've been digging into it to try and prepare for this. And I think it's definitely it's shifted my initial perspective with the caveat that obviously it's being practiced the correct way. So with as you're trying to restore someone to a homeostatic state in relative to an addiction, they come in and they're addicted to Oxycontin and with methadone. How how exactly are you progressing them and getting them back to that state through these? I mean, these not being a chemist, not being a biologist, not being a doctor, reading about these medications, it's interesting. Like seeing, okay, it's understanding the mechanism there where it's like, okay, methadone is an agonist and it blocks up some of the receptors so your body can't absorb if you're abusing other opioids, your body can't absorb them, but like to what extent? So then you're endogenously producing the chemical byproducts of consuming opioids. But how do you taper someone and carry them along that path to where, okay, now I don't have that need for the methadone or the opioid that got me here?
Now you're asking a question that I think is um very much me. because this is, when patients come to me, they are asking the exact same questions. I have to answer this question at least 15 times a day sometimes.
Well, sorry
And
for doing it to you again.
no, I'm really glad that you asked, because this is one of the reasons why I'm doing these podcasts and trying to become visible. Because when I see that, after I give the explanation I'm about to give you, the way that I see the um, understanding in the patient change, and the power that I see in them, and the commitment that I see in them, I think this is something that more people need to know. So, this is actually the big message that I'm trying to get out to the public, because, you know, um, going back, as I mentioned, like, I had the same stigma that everybody had, that if you love somebody, like, how could you love drugs more than your child, your wife, the money that you bring in? What is wrong with you? That's where I started, right? And then my attending said, well, Sarah, that's a really wrong way to think, because the disease of addiction actually changes your body. And now that I know what's happening, I, try to explain it in a very simplified way. So I'm going to take you through a journey, and follow along if you can, because I'm a visual person. And I think when you can visually understand it, it's a lot easier to see what's happening
Well, you
versus,
think because I'm blind, I'm not visual?
I think you probably have some of the best vision inside. I think the
I'm just
best sight
messing
is
with you.
inside.
Yeah.
I Okay, got it. You pulled my leg.
Yeah.
Um, but coming back to that concept, of agonist versus blocking, that chemistry, neurochemistry, that's perfect for nerds to read up on, and get have fun on. But for everybody who just wants to understand this complex method in a very simplified manner, here I go. So imagine you have a person standing on the ground, on a solid ground. Okay. So I have normally a picture of this, like, stick figure is like, there's this stick figure that's standing on solid baseline ground. And I say that at this stage, this is a person who is opioid naive, as in they have never had opioid, or they have had opioid for a very short amount of time. So their body is at homeostasis, and the ground beneath their feet is the example of being stable. Um, and so as you continue to move forward in this diagram, you have a person who starts to get opioids introduced to them, either as a prescriptive method or as a recreational method. And they start to take these chemicals on a regular basis and on a daily basis. I always like to cite something my sixth grade teacher used to say in chemistry. He used to say that the body is a bag of chemicals. So everything that's happening in our body, when we're seeing something, when we're smelling something, when we're trying to speak or move our muscle, all that physics inside our body stems from chemical reactions. And so, coming back to this, when you have this constant influx of chemicals that are coming in that's not naturally happening in your body, it starts to make your body think it needs to shift things around. It needs to change the chemical reactions, the substrates, the products to make space. It's our body's primary job is to keep us alive, right? Because if we die, the body dies. And we create natural hormones in our body known as endorphins, which are the natural equivalents of opioids. These are the hormones that lead to us feeling good, reduced pain perception, happiness, etc. The endorphins lead to the release of further hormones like dopamine and etc. And dopamine is the reward drug in our body. And most of the substances that are used, like opioids, methamphetamine, cocaine, they impact dopamine release directly. Alcohol, they impact dopamine a little differently. And then we have a few other hormones that impact our emotions and feelings, like serotonin, anandamide, etc., which is with marijuana. So coming back to this opioid spectrum. So when the body starts to see this influx and increased concentration constantly coming in, our body starts to change itself in about three ways. One of the way is that it starts to pull away the receptors where the opioids bind to, both the natural and the artificial. The second thing it does, it starts to make less of its natural hormones. So you have one, a deficit of the natural hormones as a result of this influx of extra chemicals from outside, and then you don't have enough receptors for any of these to bind to. And the third thing the body can sometimes do is increase the clearance rate of these chemicals. So basically, in many ways, to protect your life, because when you have too much opioids, what happens is that you stop breathing and you die. And that's how opioids cause overdoses, cause death.
It's
And
respiratory arrest that happens.
yes, because if you don't breathe for sufficient time, your body stops working.
Wild how that works, yeah.
It's amazing. And so our bodies are trying to save us and protect us. And so it puts us in this diseased state. And so when you have somebody who's like, I'm done with it, I don't want to use it, and they try to kick, they are kind of like at the bottom of a hole. So imagine as this body is going into this disease state, the person who was standing on the solid ground, they're slowly going deeper and deeper into a hole. And if the hole is big enough and the body doesn't have the ability to return to homeostasis, you can't go back to that normal and you don't feel good. And so the withdrawal symptoms, the way I describe them to my patients is that the withdrawal symptoms are your body's kind of like alarm system, the fire alarm system that it's breaking down, it's in danger. And I like to use the concept of cravings as your body's need to get to safety, okay?
Yeah, it's
So,
trying to get the fill of those chemicals that it had is now lacking.
the body just wants you to get to safety. I think I have to at this point, like, I feel like sometimes I have to intervene in this way because people think they are at fault for giving into their cravings or the cravings are wrong, where if you look at it objectively, the body is basically doing its job to survive. It recognizes that there's this chemical deficit, it's not functioning properly, and it can communicate to us in only limited amount of ways, still very amazing amount of ways, and that nothing moves us like pain and discomfort, right?
Having been someone who has struggled with addiction, I disagree with that. I feel like that's making an excuse for the person because
I do encounter that very, very frequently. So addiction is not a a single dimensional thing. Where you're talking about that personal will, that definitely comes and has a strong role in what we choose to do. But here I'm talking about what the body is doing.
just chemically and okay.
Right? The body is not making the decision to keep going back or not. It's you who's going to decide if you're going to go get the right help to get out of it, or you're going to keep going back to those situations that doesn't support you. And a lot of times that comes from, further psychological, emotional situations like PTSD, other traumatic events that people are trying to run away from, not having adequate resiliency or coping skills that helps people get through the hard times. So that's where the human factor comes in. So I'm talking about just what's happening in the body with addiction. And then um, in regards to what people can do, that's where my coaching program comes in to help them see the power in themselves and to continue to transcend. So, coming back to that situation of where you're stuck in this hole, your body feels like it's stuck in this hole, in that chemical gap, is what I like to call it. Now, for people who are you have to close it artificially at that stage. When the body can't close it naturally, you have to close it artificially so the body can shift its focus from survival mode to healing and recovering mode. Okay. Now, the problem with continuing to use illicitly and without proper supervision is that lack of knowledge, lack of experience, lack of accountability. as well as a threat to your safety. Because oftentimes I will discuss the urine results with my patient that, hey, did you know you had ecstasy in your urine with all this fentanyl and methamphetamine? And they will fall from the sky. And I've also had patients who are using just marijuana as far as they know, but the urine is showing that their body is seeing fentanyl. So someone is lacing what they're using without their consent with fentanyl to keep them addicted, to keep them going back to them. So those are all the risks of continuing to use illicitly instead of going to a more monitored and safe space to get that treatment. So once we have that methadone, once a patient decides that they're going to come seek methadone or buprenorphine or Suboxone to close that chemical gap, what we do, what I start to do is we slowly titrate the dose up. And the way I look for the right dose, because it varies person to person depending on how big their chemical gap is, how much they were using, how long they've been using, and what their body's ability to heal is. Because as we age, we naturally lose our ability to heal for the general population, right? Of
How big of
course,
a role does physical fitness play in that? Do you see a big corollary there?
physical fitness is a major determinant of recovery across all diseases. If you live an active, healthy life and you take care of your body, your chances of recovering is going to be so much higher than somebody your age who doesn't move much, who has an unhealthy lifestyle. Basically, they have put their body is already stressed out from their current lifestyle versus somebody who is, you know, I think here I like to use the example of a car. So allow me to deviate here.
Well, it's you I wanna make sure that we're not getting bogged down in this, like, in the metaphors and the similes here so that we can discuss some of this stuff more directly. I'm with this, you see that same corollary where physical fitness does also help people recover f from an addiction like this as well and be more capable of doing that in this as you're actually starting to titrate these doses and start to figure out what is working for the individual.
Correct. And the goal is to get to the dose that holds them for, from one dose to the next. So normally if they're taking just once a day dosing, then that dosing needs to hold them for 24 hours. And then after that, in regards to titrating, because that's the next question that comes up, that how long do I have to be on this dose for? Um, Normally, I say that there's 3 phases to this treatment process. The first phase is finding that right dose that allows your body to enter homeostasis and shift from that survival mode to the healing and recovery mode. And once it enters that, we like to have the patient hold at that dose, so I call it the maintenance phase, for a good amount of time. And then in that process, the person has the chance to also get their other life dimensions in place. So this is where, you're talking about that there's that mental element, that willpower. So figuring out how to strengthen your willpower, how to protect yourself against future encounters, how to recover from the triggers of the past. This is a good time to take care of that.
And
And then
in this phase, because I'm glad that we got here because this is something I was really curious to pick your brain on.
mhm. Yeah,
I feel like this is because I know during your residency you were able to work with homeless populations as well, and I'm very no, I think this probably gets overlooked in addiction in general, and I'm curious to pick your brain on this in working
yeah,
with homeless populations.
sure.
Obviously, or at least with my non-doctoral opinion, with my anecdotal experience, it seems to me a lot of addictions are yes, it's someone either that has become whether it's food or a substance, it's this has become a maladaptive coping mechanism someone has used instead of actually having the tools to be more in the present and process this and almost the emotional maturity is not the right term because these are tools that you have to
Yeah.
learn how to do. So I can't think of a more appropriate term there
I
other
think
than
the
tools.
term you're looking for is emotional intelligence.
Yes. So like, this is why I think a lot of people fall into addiction is not having that emotional intelligence. And with that, how much of this do you see, I guess, specifically with the homeless populations as well? Because I think another huge, everyone, I think, at face value sees that addiction is a huge part of people becoming homeless, but the mental health side of that is also huge. And I think the two go hand in hand there.
Hmm.
In
You're
your,
correct.
I guess I would imagine some of those same approaches that you've used in those more vulnerable populations have carried over into dealing with people in less vulnerable populations. But in your experience, how do you start to when there is a mental health issue there, especially something a more severe one? You've got someone who's bipolar and not being treated, or dealing with schizophrenia and not being treated. Do you have to bring in other teams to deal with that, or does your clinic have someone work hand in hand where, okay, you're on this maintenance dose, now we're going to bring you in and figure out what the core of this is outside of just behavioral components?
Um, Good question. Any good, successful treatment program needs to have multidisciplinary teams involved. We do have counselors that are drug and substance use counselors. However, just like there is different specialists of doctors, counselors and mental health support also has different specialties. So if they have other conditions like uncontrolled schizophrenia, or uncontrolled bipolar disorder, or any other, as you said, mental health condition, it's just like a physical health condition. You do want to get the right specialists on the team and help them be referred to the right folks. Um, Overcoming addiction is a multimodality approach. I believe that you need to approach all the different dimensions of a patient and help them achieve that homeostasis and all those other areas of their health as well. So remember, as I said, osteopathic principle, we believe that the body is a unit of mind, body, and spirit. And a disturbance or lack of balance in any of these fields can flow over and impact the other parts. And so you want to make sure that if there's a mental health aspect, and sometimes with PTSD as well, like it continues. It they all like impact each other. It's really hard to have um what's the word I'm looking for? Be like, oh, this is just a physical disease, or this is
Yeah.
just all mental. If you really want to help somebody, you need to help them achieve that solution in all dimensions. So, how do I think is the best way to do this? Honestly, you know, having worked with different populations, at the end of the day, everybody wants to be heard. Nobody wants to be disrespected. And there's a lot of fear and distrust there. So, having that sympathy when you're talking with the person in front of you, sympathy is not the right word, empathy, being empathetic,
Mhm.
being willing to listen, and then, establishing that rapport that, I'm here to help you, but I'm not going to solve this problem for you.
And
I
how do
can,
you balance that with, because you still have to hold them accountable too.
yes,
And I said
yes.
that's a fine, fine line.
Yes. So with my patients, when I establish that relationship with them, I tell them, you're the driver in this car, that's your body, and your life is the journey. My role is to be the GPS who gives you advice, but you have to be the one that takes it. So that's the accountability. I'm not going to solve this problem for you, but I'm going to support you within my means to help you walk this path. And I will help you figure out who else you need to have on your team, because I'm not going to be the only one who has all the answers. Um, and, so that's how I approach things with my patients. And I hope that answers your question.
Yeah. And another one, and I get this is something. guess a couple questions there, and I meant to ask you this earlier than we started talking. When you say osteopathic, I keep thinking back to anatomy and osteoblast and osteoclast with bones. And like, so when you're saying osteopathic, what exactly does that mean?
Yeah, great question. So, when people normally think of doctors, they think MD, medical doctor. Typically, we have two ways of becoming medical doctors in America. One is to go down what is called the allopathic route, and those are the doctors that get the MD degree after their name. The other path is to go down the osteopathic medicine route, and we're called DOs. We learn the same set of anatomy, physiology, pharmacology, all the sciences. We do the same residency. However, the founder of osteopathic medicine, he was an allopath who was born and lived during the Civil War times in America. And he saw the way that the doctors were approaching, sickness was from the disease perspective. They didn't care about what was happening to the person. That was also the time, hand hygiene didn't exist. So, if a soldier was shot in the leg, the treatment for that was basically amputation without second thoughts about what is this going to mean for the person who's undergoing it. Are there alternative options? You know, what's their social life gonna be like, their emotional health gonna be like? None of those were taken into account. And Dr. Andrew Taylor Steele, the founder of osteopathic medicine, he was the son of a preacher, and so he had that spiritual aspect in it, and it really bothered him. And he lost a son to pneumonia at a very young age. So all these things kind of made him a little salty against the allopathic medicine of that time. And so he went and he started to develop this other line of medicine that is more holistic, more integrative of what a person believes in, and then enabling the patient to be at the center of their healthcare. We're now at that stage where we talk about patient centered medicine, but he was the founder of this line of thinking and other things he did that makes us have the word osteopathic, and then the root for the osteopathy word is that he developed a science where we use our hands and our senses to diagnose disease, in addition to the other ways we have, like, doing ultrasound, biopsy, etc. So, using our senses with our touch, we get this extra set of skills of what's called osteopathic manipulative medicine. These words just don't sound right in modern times, but basically, there is literally manipulation of the body's tissues, like the arm, the bones, the fascia, massage, petrissage techniques to help the body go back towards the normal homeostasis and balance. So,
So how come this isn't practiced in like hospitals and stuff like that?
um, So for osteopaths to get recognized for privileges, there was definitely a big struggle. And after years of discrimination and fighting that, yes, we're doctors too, we're finally at that stage where there is more integration. It is being more recognized in regards to why is this not happening more at the hospital. I think that's more of a systematic problem that needs to be addressed over time.
So,
And then there's not enough time to do this because doing this physical work takes time, it's labor intensive. The compensation for it is also low compared to if you were to just go get a surgery done. You know, they can bill you much faster at a higher
well,
rate.
this sounds like when you hear people talk about like Reiki and stuff like that, is that I'm trying to think of I've heard of one other you hear people talking about energy healing and like that's what this sounds like. Is that are they parallels?
Good question. They're not parallels, but osteopathic medicine has respect for Reiki. This is not energy healing. This is actually physio mechanical work. There's a lot of mechanical work in it. Reiki,
How
I have been
though?
exposed to Reiki as well. My classmates in medical school was actually a Reiki practitioner. Um, so energy healing is energy. You know, um, there's that magnet.
It just
And
it sounds I'm curious because it sounds like that stuff, it sounds hand wavy when people say that. And because it's not, to my understanding, it's not empirically backed by anything. It's all it's, surveyed basically like, "Oh, okay, patients have reported feeling better after X, whether it's Reiki or these other, I don't know why I can't think of the other phrase because I had another guest on that
Mhm.
allegedly practiced that. He wasn't a doctor, but it so that's why I'm trying to delineate there. What is the difference
Sure,
between that, and because there, to my understanding, like I said, there isn't empirically backed science. So can you try
sure.
and clarify that?
I'll try my best, but I will say I'm going to give a respectful bow out to Reiki and other energy healings because I'm not a practitioner. I don't have as much knowledge. But
Mhm.
as an osteopathic doctor, I acknowledge it that for some patients it has value. And so I will let somebody who's an expert in that field talk more about what Reiki is. I can talk to you about what osteopathic manipulative medicine is. Basically, think about chiropractor work, think about massage work, think about lymphatic flow work. All of those require your hands to impact your fascial, muscular tissue um,
I believe
mechanics. Mechanics.
chiropractors aren't like actually doctors, though. I believe that is
They are licensed doctors, but they're not they're not doctors in the sense of allopathic and, osteopathic doctors who can prescribe medicine, perform surgery, um we can do just about anything that you think a doctor should be able to do. We can go into all of those specialties. Chiropractors focus mainly on the skeletal system and more so specifically on the spinal skeletal system. That's their focus. But they don't have a medical doctorate degree in that sense. Like podiatrists, they are medical doctors. They can do surgery, but they focus on just the feet.
Yeah.
You're correct that chiropractors are not licensed doctors, but they are practitioners. And there is evidence based medicine and proof for the efficacy of that as well.
Is it
Um,
evidence based in reportings of people, though? Do you know, or is it, can they look at X-rays or, MRI scans and see that the tissue is actually benefiting from this? That's where, because I think that there, even you said a very important word there. You said they're not doctors, they're practitioners. I think that is, and I'm not trying to get too bogged down in this. So I'm trying to understand here the difference here between like, the practitioners, whether that be chiropractors or Reiki people, and you where it's an osteopathic doctor.
yeah. So energy healing doesn't have the standard scientific data behind it.
Mhm.
And that's, one of the things is that I don't want to dismiss it just because we don't have Western data behind it. Okay. For a long time in the history of Western medicine, one of the things that there are blinders on where they didn't recognize acupuncture despite the hundreds of years of application in it and, some benefit in it. Homeopathic medicine, it has been in Germany, that's where it originated. They didn't they like poo-pooed that as well. So
Yeah.
it's just that now we're learning more about things. Now coming back to once again, I'm going to focus mainly on the medical aspect, which is my specialty area. Even like psychiatry, for God's sake, like just a few years ago, if a woman was having like being upset, they would associate it in the medical field with her womb. That's where the word hysteria comes from, because the origin of the or hystero is uterus. So they think if you
No
have an
way.
uterus and you're acting this way, so now you're hysterical. That's
They're
where it
like,
comes from.
wow. They're
And
like,
the
"Oh, she's just being a woman," like,
yeah,
essentially.
basically. And so how did they treat it in America, even in medicine a few years ago, right? Of maybe like
It was a
I
sexual thing, wasn't it? Wasn't that
well, I actually, yeah, you're right. There, I
yeah,
did read that, but one of the most shocking things to me is lobotomy. You know, anybody who was too extreme, too hysterical, the best way to get them to be fixed was to basically disconnect the connection in their brain with their prefrontal cortex and their other things. So basically, they turn them into a vegetable. That was a
that is so
medical
terrifying.
treatment. That was allopathic medicine, right?
Okay, yeah,
And so, that's the allopathic approach. You see a disease, you eradicate it no matter what. Let's talk about cancer. You see cancer, you take out the breast no matter what. Okay. Osteopathic medicine comes in, it's like, okay, I see the cancer. Let's talk to the person. How are you feeling? You know, breasts are a very important part of being a woman. And it's a big part of the identity as a mother, as, you know, a sexually attracting partner. How will this impact you? Before I came into osteopathic medicine, nobody would ask a woman these questions, right? Versus osteopathic medicine is not only you're asking, how are you feeling? Um, definitely let's treat the chemo, treat the cancer. What are the options and what do you want to do? Now we have that uh, s- um, state in medicine where its patient is going to be the one who decides what happens. Before we had this paternal way of doing treatment where it's like the doctor says the breasts need to come out, the breasts need to come off. There's just no if and or but around it. Versus now there's that. Now, with coming back to what do osteopaths do versus Reiki or chiropractors, we have a lot of tools that we use our hands to do things with. Like in cancer patient after they go through chemotherapy, a lot of times it messes with their lymphatic drainage system. So what you can see is lymphodiasis, where you will have like an arm or a leg, depending on where the cancer was and the treatment happened, it will get really big and really blown up because the lymph just stays there and it doesn't want to move. So one of the things we have in our disposal is we use looks like a massage to the eye that doesn't know what's the difference. But we have techniques to kind of basically massage it back, to open up those
oh,
channels. And these are, what do you call it? Like very evident, like evidence
yeah,
based. Like you can see the change with imaging, physical eyes, functionality, like regaining motion back. So you know, you if you take physical therapy, if you take massage, if you take chiropractor work, um, what else? And then there's just so much
there's a
more.
ton,
There's
yeah,
more.
and
And you put it all together, that's osteopathic manipulative treatment.
okay, and
Yeah.
I just yeah, I wanted to make sure because I know because my mind went there where I'm like, "Okay, this sounds Reiki-esque or,
No,
whatever,"
sure.
that there's gonna be people listening that hear that and are like,
Mhm.
Okay, what the fuck just happened?" So and I'm sure you probably get that quite a bit, I would imagine,
Hey,
so
I went through that myself, so you
so
know.
I
So,
appreciate you
of
letting
course.
me kinda pick that apart and try and understand that more, but
Sure. I think Dr. Steele, when he used the word osteopathy, he was thinking about how he's moving the bones around and everything that's laying on the bones around. And pathy is disease, right?
mhm,
That's the, what is the ending?
the
Gosh, I'm forgetting.
suffix.
Yes, thank you so much. That means disease. So he was thinking like I'm moving the body around and basically the bone is everything that everything is built on. So that's where I'm going to just pick the word osteopathy versus modern concept is I think the closest thing that comes to mind is functional medicine, integrative medicine. Those are the allopathic variations at this point.
Kind of synonymous, even though they come from a different school of thought. Those are like the
But that's I feel like that is the where the thought does need to go to, where it needs
okay.
to be. Yeah, labels are whatever, you can like, I like to use, Shakespeare's line here for Romeo, where he says, "A rose by any other name is still just as beautiful." So it's just all about labeling, whatever you call it. At the end of the day, it's that you're dealing with, something amazing, like the human body. And the body is so much smarter than all of our collective knowledge and information together at this time. Even coming back to the concept of addiction, the pendulum swung from being very free and willy-nilly and generous with the opioid prescriptions to like, oh my gosh, now you cannot give a single opioid even to somebody who has a broken leg or is cut open,
Yeah,
like
now we're
that's
gun shy and we're not gonna do anything.
yeah,
Yeah.
so what I like to approach this as is that medical knowledge, our knowledge of the universe, our knowledge of just the universe inside our body is going to develop every day. We're going to learn something new every day. What we think is good today will probably become obsolete down the line. But one thing that will stay true is that the body knows what to do, right?
Yeah, and I mean, it's not too long ago, we thought bloodletting was like an appropriate way to treat things. And it really, even like you talked back to the lobotomies, that was not that long ago. I
That
mean,
was not that long ago,
and
no.
that is so barbaric. And just barbaric. But, that was an accepted and,
It wasn't considered cruel at that time. Our
yeah,
definition of our ethics changes over time. Our definition of values change over time. But once again, what does not change over time are the laws of nature.
I
And
think that's a great little grain of sand to let people to sit with. And because we're coming up on the hour mark here, I
Mhm.
think that's a great spot to start wrapping this up. Can you tell everyone where they can find you?
Sure, thank you. So I think I'm gonna say mm, so I'm opening a telemedicine clinic in a few months, and it's going to be for addiction and primary care so I can continue doing that holistic um, care that I love to do. So I would invite you to find me on contact me on zenaracare.com. That's ZENARACARE.com. If you're interested in working with me, I would strongly encourage sign up so I can reach out to you and help you connect with whatever thing that I have that's gonna benefit you.
Okay. What's the
Yeah.
namesake behind Zanara?
I like I wanted to have something that has that holistic grounding homeostasis balance feel because I think when I'm taking care of the human body, I just have immense respect for seeing things in balance because no matter what direction you go to, everything I find in life, I feel like it wants to come back to being peaceful, right? And so the word Zen has that feeling for me. The concept of Zen is once again finding that balance between the yin and the yang. Um, so that's where it basically comes from.
Yeah. I wish I could see your logo because after you saying that, I was like, I bet she's got a sweet logo. I bet it.
It's a very simple logo. I
uh,
I didn't go with the yin yang one. I actually went with it's like stacking rocks. So that's the one that I'm
yeah.
trying to go for. Like just something in the center and it's very symmetrical. That's it. Very
Okay.
simple.
Well, glad to hear it. Thank you
Thank you.
seriously for
Yeah.
I know I went down some kind of pulled you down some rabbit holes there, but I'm very curious and I think a lot of the listeners are too, and I want to know and understand that stuff. So thank you for letting me do that and elegantly handling it, not getting frustrated with me for asking my questions, and thank you for taking the time.
Of course, I always enjoy, a stimulating discussion, and especially when I have somebody who is able to contribute to the conversation as deeply. That's a treat for me. So I appreciate you having me on the show and also, engaging with me in such a meaningful and with so much depth. It's been a pleasure talking with you.
Yeah, thanks. And thanks everyone at home for listening to another episode of Going In Blind. Remember, if you haven't already, please rate and review the show wherever you listened, and then share this conversation around with someone who needs to hear it.